بسم الله الرحمن الرحيم. نكمل محاضرتنا حول heart disease. هو the other disease هو rheumatic fever. Rheumatic fever is a disease which sometimes follows a sore throat caused by certain strain of beta hemolytic streptococci. Children between 5 and 15 years are primarily affected by rheumatic heart fever. Rheumatic fever may occasionally be followed by chronic rheumatic carditis with permanent cardiac valve damage. The inflammatory reaction of rheumatic carditis appears to result from immunological cross-reactivity with streptococcal antigen and immunologically mediated tissue damage, which may lead to, after the lapse of years, to fibrosis and distortion of cardiac valve. Chronic rheumatic heart disease. A clinical feature of rheumatic heart disease. The sore throat may be followed by, after about 3 weeks, 2 to 26 weeks, by an acute febrile illness, with pain flitting from one joint to another, migratory arthralgia. Usually, there is resolution within 6 to 12 weeks without apparent after effect. Pain in large joint which give rheumatic fever its name. We have cerebral involvement causing spasmodic involuntary movement, like Sanham's chorea st vitreous dance, a characteristic rash like erythema magnetism, lung involvement, subcutaneous nodule usually around the elbow. This figure shows the scandaneous chorea that have white patch at the tonsillar area. This figure shows the red patch in the erythema magnetism in the skin. This figure shows the nodule within the elbow. The most serious cardiac complication is subendocardial inflammation, particularly along the lines of closure of mitral and aortic valve cusps, resulting in the formation of minute fibrinous vegetation and later scarring. There is usually little detectable effect on cardiac function in acute phase, but in unusually severe cases, myocarditis can cause death from cardiac failure. The essential feature of chronic rheumatic heart disease are a fibrotic stiffening and distortion of the heart valves, often causing mitral stenosis. This is essential a mechanical hemodynamic disorder in which the defective valve may get infected at any time, leading to infective endocarditis. Cardiac failure can develop often after many years. How we do general management for patients who have rheumatic heart fever. The clinical manifestation of acute rheumatic fever are so variable that the diagnosis should not be made unless at least two of the major criteria are fulfilled. We have minor criteria and major criteria for rheumatic fever for diagnostic criteria. The minor criteria as pyrexia arthralgia, previous rheumatic fever, ESR, and C-reactive protein rise. The major criteria as carditis polyarthritic, arthritis chorea, erythema magnetism, subcutaneous nodule, characteristic feature of ECG changes. This figure shows the normal joint and joint with rheumatic fever. There are inflammation of synovial membrane and synovial joints. This figure shows deformity of the joints of the hand and legs. This figure shows the nodules red nodules within the erythema magneterium. This figure shows the elbow nodules within the elbow joints. This figure shows the changes in the ECG, that one of the major criteria for the present illness of rheumatic fever. A preceding streptococcal infection is confirmed by high or rising titer of anti-citrullinated O antibodies, and this is suggestive but not diagnostic of rheumatic fever. However, a low ASOT virtually excludes the diagnosis. Treatment consists principles of the use of salicylate and penicillin if the streptococcal infection is still active. Promote antimicrobial treatment within 24 hours of onset of streptococcal sore throat. Prevent the development of rheumatic fever in most cases. Complications such as cardiac failure are treated along conventional lines. Chorea may recur during pregnancy or in patients taking the contraceptive pill, but does not indicate recurrent carditis. After an attack of rheumatic carditis, there is risk of recurrence, and continuous antibiotic prophylaxis becomes necessary to lessen the risk of permanent cardiac damage. The drug of choice is usually oral phenoxymethylpenicillin 500 mg daily until the age of 20 years. For those allergic to penicillin, sulfamidine 500 mg daily by mouth should be given. The mitral valve is usually affected either alone 60 to 70% or with aortic valve in further 20% in cases. The aortic valve alone is affected only 10%. Valve narrowing as stenosis and regurgitation as incompetence are associated in varying degrees. Earliest sign of valve damage is murmur. Later effects, particularly enlargement of the heart, may be detected clinically, radiographically, and by ECG and echocardiography changes. Treatment is by mitral balloons valvoplasty using an balloon. How dental treatment for patients have rheumatic fever? In acute rheumatic fever, patients are accidentally unlikely to be seen during an attack, but emergency dental treatment may be necessary. It must be emphasized that all rheumatic heart lesions are at risk from infective endocarditis, but the level of risk is not related to the severity of the defect. The rheumatic heart disease, don't forget this problem. The last diseases that discuss with you about heart problem is infective bacterial endocarditis. It is a rare but a dangerous, potentially lethal infection, predominantly affecting heart valve. Case range from preventing acute to chronic. General aspect of infective endocarditis result from two main predisposing factors. First, bacteremia, mean the presence of bacteria within the bloodstream. Second, cardiac lesion, where there is turbulent blood flow. The etiological factor for infective endocarditis. First, numbers of bacteria entering the blood. Second, ability of bacteria to adhere to endocardium. Third, host factor increasing susceptibility. Local lesion, congenital, rheumatic and other acquired valvular disease, prosthetic heart valve, other cardiac disease, protective factor, antimicrobial chemotherapy. The virulence streptococci such as Streptococcus mutans and Streptococcus aureus account for more than 50% of the many different causative organisms of infective endocarditis. Others implicated include particularly Staphylococcus aureus and Enterococci. Viridans streptococci have complex attachment mechanisms which may enable them to adhere to the endocardium. Viridans streptococci proliferate where oral hygiene is lacking and proliferate into the bloodstream in large number, particularly during tooth extractions. Oral bacteremias after tooth extraction are generally transient and last for less than 15 minutes, but occasionally last for up to 1 hour. However, viridans streptococci are also released into bloodstream during chewing and home oral hygiene procedures. The pathogenesis causing the infective endocarditis. There are many pathogeneses that have. The most common one, Staphylococcus aureus, second, Streptococcus epidermis, Streptococcus viridans, Enterococcus, and diphtheroid, Procella, Coxiella burundtii, fungus, and other unknown microorganisms. The approximately the prevalence of bacteremia following various oral manipulation as bacteremia between 0 to 0.25%, between 25 to 50%, between 50 to 80%. Denture procedure is scaling and root planning, extraction of tooth, multiple tooth extraction, oral hygiene procedure, periodontal prophylaxis, toothbrushing, periodontal surgery using of interdental sticks, flossing, water irrigation, and chewing. The cases of infective endocarditis. No obvious cardiac valve disease in 14, chronic rheumatic heart disease in 13, and congenital heart disease, prostatic cardiac valve, and intravenous drug abuse in 10. The risk of infective endocarditis and after dental treatment. We have high risk as antimicrobial microprophylactic and concentration essential as in prostatic valve, previous infective endocarditis, and complex congenital heart disease. Intermediate or moderate risk, antimicrobial prophylaxis considered necessary in virtually any uncorrected cardiac valve disease and some other congenital defect, premium arterial septal defect, ventricular septal defect, patent sulcus, patent ductus arteriosus, bypass aortic valve, co-irrigation of aorta, surgically corrected cardiac defect, hypertrophic cardiomyopathy, rheumatic heart disease, various systemic disorder like syphilitic heart disease, systemic lupus erythematosus, coronoid syndrome, and ankylosing spondylitis, and other. In negligible risk, antimicrobial prophylactic considered not needed, like after myocardial infarction, after coronary artery bypass graft, is isolated septum arterial septal defect, and others. The peak prevalence of infective endocarditis now the 6th or 7th decade, and the disease is very uncommon in children. The mitral valve is affected between 28 to 45% of cases. The aortic valve is between 5 to 36%, both in between 0 to 35%, and tricast valve in less than 10%. Intravascular access device such as central intravenous line, Hickman line, or Aldal catheters often become infected, but there is no evidence for a dental focus for such infections. Clinical feature of infective endocarditis in the previously healthy patient who acquire endocarditis due to viridient streptococci. The picture is likely to be that 3 to 4 weeks after dental operation. There is insidious onset of low fever, mild malaise, pallor anemia, light cafe or late pigmentation of the skin, joint pains, hepatosplenomegaly are typical. The main effects of endocarditis are progressive heart damage, infection or embolic damage of many organs, especially the kidney. Increasing disability associated with changing cardiac murmurs, indicative or progressive heart damage. While release of emboli can have effect ranging from loss of a peripheral pulse to rarely sudden death from a stroke. Embolic phenomena include hematuria, which is common, cerebrovascular occlusion, petechia or purpura of skin and mucous membrane, splinter hemorrhage under the fingernails, and finally, growth spot or small retinal hemorrhage. Immune complex formation from the antigen and resultant antibody, which can lead to vasculitis, arthritis, renal damage, ocellaris nodes are small, tender vasculitis lesion in the skin. Without treatment, infective endocarditis may be fatal in about 30%. General management. The first diagnosis is based on changing murmurs, ECG, echocardiography, and blood culture. At least 320 ml sample of blood should be taken aesthetically at half-hour interval to increase the chance of obtaining a positive culture. The heart murmurs often arise from inflammation of multiformation of the heart valve, as you see in this figure, the involvement of aortic valve or tricuspid valve. This figure shows the changes in the ECG of the patient, taken for diagnosis of infective endocarditis. This figures echo as echogram are taken to see left and right ventricle and aorta. The usual treatment is intravenous penicillin plus gentamicin for 2 weeks or more if viridient streptococci are the causes, but the bacteriological findings determine the choice of antibiotic. In severe cases such as prostatic valve or candidal endocarditis, early removal of the infective valves and insertion of steroid replacement can be highly effective. How deal with the dental management of patients who have endocarditis? Antimicrobial prophylaxis agents against endocarditis and thus for medical legal reasons, it remains mandatory to give such prophylaxis to patients at risk as follows. Patients at risk for endocarditis should receive intensive preventive dental care to try and minimize the need for dental intervention. There is no reliable evidence to suggest that electric toothbrush or water picks or similar device poses a risk. From the purely dental standpoint, it is obligatory to try to prevent the onset of infective endocarditis in the view of the high morbidity and mortality. Identification of patients at risk lends preventive dental care, deciding which treatment require antimicrobial cover, giving the appropriate antibiotic at approach time. This is for previous endocarditis and prosthetic cardiac valves. A relative history, and patients should therefore be asked if they have or have had valve defect acquired, such as in some intravenous drug abusers. Congenital, as mitral valve prolapse, is common and usually asymptomatic. Cover is required for it only when it gives rise to a murmur and there is regurgitation and thickened valve leaflets. We have heart surgery and its nature. We have heart murmur as heart murmur, previous attack of infective endocarditis, any other heart disease and its nature, a history of rheumatic fever. So this is rarely useful in itself. Over 40% of cases of infective endocarditis involves a normal heart or unsuspected defect. Patients with Down syndrome have high frequency of congenital heart defects such as mitral valve prolapse, immunodeficiency, a tendency to gross plaque accumulation, and periodontal disease. Yet, despite these three factors that should favor it, they do not appear to be particularly susceptible to infective endocarditis. Planned preventive oral health care is needed for all patients who have prosthetic heart valve or who have already had infective endocarditis, particularly those with congenital or rheumatic heart disease. The aim is to keep periodontal infection at its lowest possible level, to avoid the need for extractions, or if extractions are unavailable, to lessen the severity of bacteremia by keeping the gingiva healthy. The antibiotic prophylaxis is mandatory for certain type of dental treatment. Particularly, this management of a dentition needs a prophylactic antibiotic, like extractions, subgingival procedures, including propping or crowd placement or scaling, oral or periodontal surgery, or raising mucogingival flaps for any other purpose, including implants. Endocarditis, endodontics beyond the root apex, serography, intraligamental local anesthesia, rubber dam, matrix, or wedge placement. This must use antibiotic prophylaxis. This procedure not need a prophylactic antibiotic like dental radiography, endodontic not beyond apex, exfoliation of primary teeth, impression taking, non-surgical procedure that do not induce bleeding, abscess, incision and drainage, suture removal, orthodontic band removal, and finally biopsy not need a prophylactic antibiotic. The recommendation of prophylactic antibiotic as follows. Patient at high or moderate risk for infective endocarditis not requiring a general anesthetic, as not allergic to nor have received more than a single dose of penicillin in the previous month. Adults 3 gram amoxicillin orally 1 hour before the operation, taken in the presence of the dentist or nurse. For children 5 to 10 years, 500 mg for children under 5 years, 20 to 150 mg used as amoxicillin. Note: 3 grams of amoxicillin can be given on not more than 2 occasions in mouth, as this dose is sufficient to destroy the relatively resistant streptococci that have emerged, and patients allergic to or who have received more than a single dose of penicillin in the previous month, adult single oral dose of clindamycin 600 mg for an adult, and can be given 1 hour before the dental procedure, or 500 mg of azithromycin or clarithromycin. For children 5 to 10 years should have one half the adult dose as 300 mg, and children under 5 years should have 1/4 of adult dose as 150 mg. Clindamycin in single dose is not known to cause pseudomembranous colitis. If clindamycin is used, multi-stage procedures requiring antimicrobial prophylaxis should not be repeated at intervals of less than 2 weeks. Alternatively, 1.5 gram erythromycin citrate can be given orally under supervision 1 to 2 hours before dental procedure, followed by a second dose of 0.5 gram 6 hours later. For children 5 to 10 years, one half the adult dose. For children under 5 years, 1/4 of adult dose. Children can be given azithromycin for 5 to 10 years as 300 mg. For children under 5 years, we can use azithromycin as 200 mg. Treatment under general anesthesia or intravenous sedation or unable to take oral medication, patient with natural valve disease and no history of infective endocarditis. Example, no special risk, but not allergic to nor have had penicillin more than once within the past month. Amoxicillin 2 gram IM or IV before induction plus 500 mg of amoxicillin orally 6 hours later. Alternatively, 3 grams of amoxicillin may be given by mouth 4 hours before induction and repeated as soon as possible after recovery. If the anesthetists agree, if allergy to penicillin, clindamycin is used. Treatment under general anesthesia patient with prosthetic valves or previous endocarditis. Patient at special risk, not allergic to nor have had more than a single dose of penicillin within the past month. Amoxicillin 2 gram IM or IV plus gentamicin 1.5 mg per kg or IV immediately before induction. A further 1 gram of amoxicillin should be given IV later or orally 6 hours later. If allergic to or have had a penicillin more than one in the past month, vancomycin 1 gram by IV infusion over 100 minutes followed by gentamicin 1.5 mg per kg IV before induction. Vancomycin, if given too rapidly, can cause facial or widespread erythema, red man syndrome, among other toxic effects. Therefore, alternatively, IV teicoplanin 400 mg plus gentamicin 120 mg may be given at inductions, or IV clindamycin 300 mg may be given 100 minutes before induction, followed by oral clindamycin 150 mg after 6 hours. Patients who have had a previous attack of infective endocarditis or have prosthetic valve, irrespective of the type of anesthetic, but are not allergic to the penicillin and have not had penicillin more than once in the previous month. Amoxicillin 2 gram IV plus gentamicin 1.5 mg per kg, IV immediately before dental procedure. A further 1 gram of amoxicillin should be given IV both operatively or orally 6 hours later. Additional measures. Application of antiseptics such as 100% pyridine iodine or 0.5% chlorhexidine gel to the gingival cervix or chlorhexidine 0.2% mouth rinse 5 minutes before the dental procedure may be reduce the severity of any resulting bacteremia and may be useful to supplement antibiotic prophylaxis in those at risk. Good dental health should reduce the frequency and severity of any bacteremias and also reduce the need for extraction. It is essential that even when antibiotic cover has been given, patient at risk should be instructed to repeat any unexplained illness. Infective endocarditis is often exceedingly insidious in origin and can develop 2 or more months after the operation that might have precipitated it. Late diagnosis considerably increase both the mortality or disability among survivors. Patients at risk should carry a warning card to be shown to their dentist at each visit to indicate the danger of infective endocarditis and the need for antibiotic prophylaxis. If multiple visits are unavoidable for dental care, this should be spaced by at least 9 to 14 days to try and limit the emergencies of antibiotic-resistant microorganisms. It must be accepted that although neither the need for nor the efficiency of antibiotic prophylaxis can be established in any given case, antibiotic must be given before extraction, scaling, surgery involving dental tissue to patients with recognized predisposing cardiac disorder. In addition, it is essential to warn patients whether or not antimicrobial prophylaxis has been given, to report back if even a minor febrile illness developed after dental treatment. It must be remembered that patients at risk from infective endocarditis may also have a heart lesion that makes them a poor risk for general anesthesia and if you are on anticoagulant treatment for other drugs. Possible prophylactic antibiotic regimen against infective endocarditis. The regimens have United Kingdom as the British Society of Antimicrobial Chemotherapy done in 1992. A. Amoxicillin 3 gram 1 hour before treatment. If allergy to penicillin, clindamycin 6 mg 1 hour before treatment. The other regime, the European Consciousness, done by 1995. A. Amoxicillin 3 gram 1 hour before treatment. If allergy to penicillin, clindamycin 300 to 600 mg per hour, 1 hour before treatment. American Heart Association, done in 1997. Amoxicillin 2 gram 1 hour before treatment. Clindamycin 600 mg 1 hour before treatment. Thank you for listening.